You want me to change the background? Is it okay? Or should
Yeah, yeah,
I?
it's
Is it
okay. It's okay.
okay? Fine.
So we are live now. Very good afternoon to one and all. I am Arpita, the moderator for today's session from the IGCP group. The topic that we are going to cover today in our webinar is addressing challenges in insulin therapy. And yes, to address this topic, we have with us someone very eminent and very known to everyone, Dr. Sudhir Bhandari sir. Though sir doesn't need any introduction still for the formalities. Sir has done MD, DNB, MNA, MS, FRCP from London, FRCP from Edinburgh, Fellow American College of Endocrinology. He's a Fellow of American College of Physician, Fellow Indian College of Physicians, Fellow Research Society for the Study of Diabetes in India. He is a Professor Emeritus, SMS Medical College and attached group of hospitals at Jaipur. Sir is a Pro-Chancellor Group Jaipur National University, that is a JNU, and Institute for Medical Sciences, Jaipur. So, with this very brief introduction of Sir, now I would request him to please start with the presentation for today. Over to you, Sir.
Thank you very much. It's been a pleasure to be on your Meditalk platform, and I must thank IGCP for having invited me. We are going to talk about a very interesting topic addressing challenges in insulin therapy. You need just hang on. This is the basic crux of every diabetic whom we treat. The most powerful agent we have to control blood glucose is insulin. We need to understand that every fifth person in our country is either diabetic or pre-diabetic. The day type 2 diabetes is diagnosed, 50% of beta cells are knocked out and insulin production is 50%. You know that all type 2 diabetic patients over the period of time they become insulinopenic. It means suppose the insulin production at this level over a period of 5, 10, 15 years the insulin production goes down, 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 and a condition of secondary failure comes. It means whenever the blood glucose level is more than 200 fasting and post meal more than 300 with 2 to 3 anti-diabetic drugs, and patient is losing weight, so no response to 3 anti-diabetic drug, patient losing weight, it is a sign of insulinopenia or insulin deficiency, and that's the time in type 2 diabetic patient we need to introduce insulin therapy, which is resisted by most of the patient. And all you know, the type 1 diabetes is autoimmune diabetes where the patient's life depends upon the adequate insulin supplementation. So insulin is very important tool in management of hyperglycemia. The challenge with insulin is that it is available only in the injectable forms. Different types of insulin, short acting, intermediate acting, and long acting are available. Insulin nasal sprays and insulin pumps are in vogue, but they are on the experimental stage. So when we talk about the perfect glycemic control, insulin becomes integral part in type 2 diabetic treatment as well as essential part in type 1 diabetic treatment, and we need to use it very effectively. And probably there is a lot of resistance which is seen by the patients when we are proposed to insulin. Why insulin is so important in our armamentarium of controlling diabetes? An anti-diabetic drug is assessed by the ability of this drug to reduce HbA1c. If you look at among oral drugs, sulfonylurea and biguanides are very potent to bring about HbA1c, and rest are 1 to 1.5. But if you look at the insulin, the reduction in HbA1c in insulin therapy may be as much as more than 2.5. And that's the reason, that's the potency of insulin in bringing about the ability to reduce the blood sugar. Hence, we need to be very used to the insulin therapy, which is very important. But there are a lot of barriers to the use of insulin. There are a lot of challenges before we use the insulin. So initially, I'll talk about the few challenges when we propose insulin to the patient, which we come across. But after that, I will share how important is the insulin in our diabetic management portfolio, that we have to very scientifically deal with these challenges. So there are a lot of barriers. These barriers could be at a different level. Barriers could be at the patient level when patient's education level is so much not so educationally updated that his acceptance is good. Socioeconomic status patient may not be so rich to afford it. Attitude towards life that एक बार इंसुलिन शुरू किया तो जीवन भर लगाना पड़ेगा. His physical health and mental health is not permitting him to take the insulin. Emotionally, he is not prepared to take insulin. There could be some educational barriers also, like patient may have poor vision and he may not be have the advantages of insulin aware of it. His professional requirement is that he is too preoccupied that he has no time to take insulin in timely knowledge time. The knowledge about it's poor, and at the same time, like there could be some religious beliefs not to take injectables, while there could be environmental barriers which could be from stress to the reimbursement issues, the weather, climate, very hot countries, they have a big issue. The poor people in the rural area, that how do we maintain the insulin without having fridge? So there could be so many factors which attributes to the barrier. But the most important barrier to insulin therapy is individual resistance not to accept insulin. But after talking about few of the challenges which we come across in insulin therapy, I'm going to share with you how important insulin is, that we have to meet out these challenges. When we want to give insulin, the thought behind is that we maintain good HbA1c of less than 7%. At the same time, we want to ensure better quality of life, which is important. When we talk about the insulin therapy, there are different type of insulin therapy. If you look at the white curve, is a short-acting insulin therapy. The red curve, it is an intermediate acting insulin therapy, and the blue and the green shows long acting insulin therapy. So we have a lot of options available for the insulin therapy, but then we need to be very careful about which to opt for what. Each person is unique and they have a unique exercise plan, the meal plan, the other professional and occupational routines. So we need to make a tailor-made insulin so that it meets out their profile of activity. When we talk about the insulin, it is very important. We need to listen to the patient first, and then gradually we need to educate the patient, which is very important. When there is a indication to start insulin, which I'll be talking to you later, we need to know which insulin regime will fit best for the patient, which will be the insulin best for the patient. With if there's a history of hypoglycemia, we'll have to be very careful about short acting insulin, which causes a lot of hypoglycemia. We'll have to go for basal insulins or long acting, which is a less incidence of hyperglycemia. And what are the expectation, how much HbA1c we want to bring it down? The patient cannot be dictated to, but must be a partner in our decision taking whenever we plan for insulin therapy. So this is the first crux, that to overcome the challenge of starting insulin therapy, he should be partner. At the end, patient must make a choice. It is he or she, not you, that who has to live with insulin therapy. Hence, you need to be very careful about it. We need to aim at good glycemic control. We need to decide if sugar is high, how much low has to be brought, and if it is low, how much dose reduction we have to do, which you to be very correct about it. There are many situations where the risk of hyperglycemia may modify our treatment. Like if the patient is young, below 8 years or above 60 years, patient has a CVD, patient has complications, patient has hypoglycemia unawareness, patient has job risk, sleeping alone, we need to modify the dose of his insulin. So another challenge we have, that depending upon the age, the comorbid condition, and the need of the patient, we need to modify the doses. There are certain situations where we need to do under correction if there's a frequent hypoglycemia, there's significant comorbid condition. While at the same time, if the patient is young, healthy, aware of the hypoglycemia, fit and compliant, we need not to reduce the insulin therapy dose so much as we need to do with the patient who are not compliant. It is always nice to ask why. Why the patient should be taught that you should always ask why my sugar is high. If he does the introspection, he'll come to know how much sweets he have taken, why sugar is low, and all kind of introspection need to be taught to the patient. And now, having realized that insulin is so important in our day-to-day management of diabetic patient, how insulin is important, why insulin is important, which I'm going to talk about. Look, this slide is one of the most memorable slide that Banting and Best, who discovered the insulin from the dog's pancreas and first time treated. Look at the before insulin, you look at the baby who was emaciated, and once the same patient was put on extract of the dog, the patient improves, sugar went down, his health improves, and this is the miracle which insulin therapy brings. And diabetes is a group of metabolic disorders which is diagnosed by impaired insulin secretion and insulin action known as insulin resistance. So, truly speaking, the diagnosis of diabetes begins with insulin deficiency and insulin resistance. Hence, the insulin become an important part of diabetes treatment. You should know that you may require insulin in type 1, type 2, LADA, MODY, gestational diabetes, and secondary diabetes. So these are the so many indications, and hence we need to overcome all the challenges, these indications. In type 1, there is a total autoimmune destruction with 80 to 90% of beta cell got destroyed, and hence insulin is mandatory in type 1 diabetic, but it is so sensitive because that is a juvenile or the adolescent age where convincing the patient for basal bolus like 3 to 4 injections a day, it is a big challenge and you will have to be very patient. This pathophysiology, all that this is the etiology of hepatic gluconeogenesis, decreased uptake by muscle and decreased insulin by pancreas, causing hyperglycemia in type 2 diabetic patient. Just hang on, my slide is not moving.
Sir, this is the last slide as it
No,
is
no, no,
showing.
no, ma'am. There are lot many. Oh, no, no. There was other presentation, ma'am. Yeah, yeah. There are lot many other slides, ma'am. So, yeah,
Okay.
yeah. There are other slides, ma'am. Sorry. Sorry, ma'am.
So I think this is the other PPT that has been uploaded. There must be another one because in this PPT, this one is the last slide it is showing.
Ma'am, just 1 second. We are uploading.
Yes, yes, no problem. No problem, sir.
सर मैं इनको व्हाट्सएप कर दूँ इस स्लाइड को, तो ये वो कर दें तो अपनी तरफ से अपलोड कर दें तो
हम क्यों नहीं यहाँ से चला सकते?
मतलब उसमें अपलोड तो कर रखी है सर, लेकिन आ नहीं रही है पूरी.
Is it coming, ma'am?
No, sir, I think you need to remove this slide and then
Remove
upload
and
the
we'll
another
put it.
correct version.
Yeah, I'll put it again, ma'am. Just hang on.
Yes, yes, sir.
थोड़ा वो सेट वापस डालना.
वीडियो बनाकर बोल रहे थे, पीपीटी सुनने हो रही थी, चल जाएगी पूरी सा. आगे से मैं करूँ तो एक मिनट पढ़ा दो.
Yes, sir. Now all the slides have come.
Yeah. So this is the way how insulin is important, that after this child on the left side who was insulin deficient, when Benting and Best discovered insulin, they injected to the baby who improved in health, muscle improved, and that's it important. So it is a disease. All of us know that it is a disease of insulin deficiency and insulin resistance, and hence insulin is so important. As I already talked to you, that this is the natural history of diabetes in which insulin resistance build up, and hence insulin resistance means suppose your body is producing 100 units of insulin, it works only at the 50 units because of the ineffective efficiency of the insulin, and there is a beta cell destruction. Could you see the blue curve touches the baseline after a few years, and there is a total beta cell destruction or apoptosis, and patient become insulin deficient, and here is the time when you require insulin to be given and you face the resistance of the patient. And as the insulin level goes down, the blood sugar level goes up, fasting blood sugar level goes up. Why we need to control the diabetes so effectively? All of you know that it is very essential to control diabetes effectively, because if you don't bring down the HbA1c to as low as 7%, there's an increased chances in all the studies like DCCT, Komamoto, or UKPDS, there's an increased incidence of retinopathy, nephropathy, neuropathy, and macrovascular disease. That's the reason you need to have perfect glycemic control, and which can be achieved with insulin, and one need to be very careful about it. And you know what is the diagnosis of diabetes. I need not to repeat. When fasting sugar is above 126 and post meal sugar is above 200, we call it to be diabetes. You know about it. This is the diagnostic criteria of diabetes as per ADA: 90 to 130, more than 180, and HbA1c more than 7, which is very important. Now, when we talk so much about insulin, why insulin is essential, why we are after insulin in spite of patient being so resistant, we need to understand the good physiological effect of insulin. It increases on liver glucose uptake, and it inhibits the glycogenolysis and gluconeogenesis. So there's a lesser release of glucose from liver into circulation, and hence the sugar is taken care of. It increases the muscle uptake of glucose, and it also reduces the fatty acid mobilization. So because of these are wonderful physiological effects of insulin, that it is very essential. Now, when to start insulin? This is very important. There are absolute indications of insulin, and hence we need to understand there's no other alternative than to start insulin, even if the patient resists, patient has a barrier to take insulin, all type 1 diabetics, in diabetic ketoacidosis, serious infection during and after major surgery, pregnancy, failure to achieve HbA1c with 2 to 3 oral drugs when it is more than 10, kidney and liver diseases and acute stroke, we need to start insulin even if the patient has reservation. The relative indications are micro and macrovascular complications, underweight, losing weight. If the patient is going very thin, we need to think of insulin. Symptoms of blood sugar more than 200 milligram percent, all the symptoms of hyperglycemia, polyuria, polydipsia, loss of weight in spite of having good appetite, all hospitalized ICU patient, any patient who's on high dose of steroids, for example, the autoimmune disease or systemic lupus erythematosus, we need to be very careful. And when duration of diabetes more than 30 years, we need to be very careful about it. Why to start insulin? Because we want to prevent the complications, prevent the ketoacidosis, and prevent the flare-up of serious infections. After, during, and pre-surgery also we need to add on to insulins. And same with the pre-pregnancy and antenatal to the post-pregnancy. We may switch over to oral, but insulin has to be started. Why to start insulin? When there is a failure to achieve control with 2 to 3 days, when the HbA1c is more than 10 and fasting sugar is more than 250 milligram percent, when hepatic and the renal failures are there, we have no alternative than to start insulin. When we try to talk to a patient that you have to be on insulin, we need to understand what are the advantages of insulin therapy. It is the most effective diabetic medication, and we have the very good beneficial effect of on triglyceride and on increasing HDL and reducing triglyceride, which is very important. But all that glitters is not gold. Insulin has a great advantage, physiological advantage, but there are some challenges also. Insulin therapy also lead to the weight gain. There could be 2 to 4 kg of weight gain and the risk of hypoglycemia. This is the only one of the biggest deterrent of the patient to insulin therapy. So we need to be very careful about hypoglycemia awareness in patient of type 1 diabetes as well as type 2 diabetes, and we need to be very careful about it. Then next question comes, if you have thought of insulin, which insulin to start? There used to be earlier bovine and porcine insulin, but they were highly antigenic, now no more used. Human insulins, they are regular insulin, intermediate insulin, and long-acting insulin, and insulin analogs, Lispro, Aspart, Glucicin. Here, friends, I like to share with you that conventional insulin, bovine, porcine, we don't use. Human insulin are very good insulin, but insulin analogs are better. Why? Because insulin analogs mimic the normal physiological response. What is normal physiological response? When we eat food, there is a first phase insulin secretion for first 20 minutes, followed by second phase, which takes care of complete food. But when we give insulin analog, the onset of action is 1 to 2 minutes. So there is an immediate rise in insulin levels, and it mimics the physiological phase 1 of the normal person. While if we take the conventional insulin, the onset of action will be after 30 minutes. So it will not match the phase 1 and phase 2 of the insulin therapy of the common people. This is one you need to understand. That just 1 second, okay? Just hang on. There's some problem with. Yeah, that comes that you need to. So which to start? So we'll always prefer the insulin analogs because they are more physiological than human insulin. One need to have the perfect understanding of short acting insulin, intermediate acting insulin, and long acting insulin. This curve should be imprinted in your mind that short acting insulin, they work for 2 to 4 hours, intermediate for 8 to 12 hours, and long acting insulin for 14 hours to 24 hours. And we have these days Digludec, which is effective for 42 hours. Then you need to have a perfect knowledge about types of insulin. The types of insulin could be premix insulin, which could be 30/70, which could be 50/50, and which could be like 25/75 in case of analogs. When we talk about 30/70 or 75/25, it means the long acting is 70 and short acting is 30 or 25. This is used twice a day in those people who take three proper meals: breakfast, lunch, and dinner. So use it before breakfast and before dinner. If you use the 50/50, it means the 50 is a short acting, which takes care of immediate meal, and 50 is a long acting. So you should take, there are two type of people: one who take breakfast, lunch, and dinner. Second is who take one morning meal before going to bank or office. They take 10 o'clock the proper meal and then take another heavy meal at 6 to 7 p.m. So you give 50/50 to them. So another challenge which you have is that you need to know that what kind of food habit the patient has and what kind of insulin combination and premix you to use, whether 50/50 or the 75 and 25. Then how to start insulin in type 1 diabetic patient? Type 1 diabetic patient are lean and thin patient who are totally insulin deficient. So you need to have a perfect knowledge of the insulin doses, and that is also one of the important challenge to calculate the doses. The normal dose requirement is zero point 0.5 to 1 units per kilogram of body weight. You can start with 0.5 to 0.75 and then can maintain it with maintenance doses. Now, once you have calculated the insulin doses, next comes, would you prefer the multiple injection regime, that is basal bolus, or will you prefer the premix? When you opt for basal bolus, you need to give 50% as a basal and 50% as a bolus. It means all the three meals, breakfast, lunch, and dinner in type 1 has to be covered by short acting insulin by 50% dose, and long acting or the basal insulin is given in 50% dose. But if you use a premix, that is 30/70 or 50/50, you need to use 2/3 dose in morning and 1/3 dose in the evening, pre-dinner and pre-breakfast, so that you have to make a tailor-made selection of the insulin therapy, type of insulin therapy, doses of insulin therapy, which is very important. This is one step, that is initiating insulin. Bedtime intermediate acting or long acting insulin can be given, and bedtime long acting insulin can also be given. That really takes care of the whole. You should know that in 24 hours, we are in a postprandial phase 17 hours a day. So we would require a basal insulin. And we should know the food pattern, we should know the pathophysiology, we should know the profile of the patient. So basal insulin is must to meet out the fasting hyperglycemia and the basal hyperglycemia. We plan the insulin therapy for the patient. We need to step by step plan. First of all, we need to understand the patient's regime, and then we can plan insulin regime should be designed taking lifestyle and meal schedule into the account, which is very important and which can happen. Checking of blood sugar and increasing the doses is very important. When you plan for the insulin therapy, you have to calculate the sugar levels properly, and you know CGMH, fasting, pre-lunch, post-lunch, pre-dinner, post-dinner, so that you can plan the insulin doses upgradation or downgradation, and we need to be very careful. The typical dose increase of 2 units every third day if fasting glucose is more than 180, and you can increase the insulin. And similarly, you have to bring down the doses of insulin. That is also. So insulin therapy is not like simple tablet that you prescribe and you forget about it. The another challenge with insulin therapy is that patient has to be in constant touch with you through CGMS report, or they could be dynamic monitoring like Libra monitoring and share the insulin reports with you, and you can adjust the doses of insulin therapy, which is very important. You need to be very careful that patient doesn't have hypoglycemia when you give insulin under 70 milligram percent. And if it goes in hypoglycemia, you need to reduce 10% of insulin, that is 3 to 4 units, or it can be used. There's no problem at all. Now, another very important thing, that what do we do to intensify the treatment, because we want to achieve the perfect glycemic control. If pre-lunch blood sugar is out of range, it is very important, because you need to intensify, and this is the biggest challenge in insulin therapy. If pre-lunch sugar is out of range, you need to add rapid acting insulin at breakfast. If pre-dinner blood sugar is out of range, you need to add rapid acting insulin at lunch. That you need to be very careful about it. And if your pre-bad blood glucose is out of range, add rapid acting insulin at dinner. So you need to be very careful. If the lunch and dinner are post lunch and dinner sugar are high, we take care of short acting insulin or rapid acting insulin. And if the fasting is high, we take care of long acting or the bolus insulin. This is very important. Minimal adjustments is very important, and you can begin with 4-unit increase or 4-unit decrease in the patients when you see the fasting and other sugar volumes. Now, you need to understand that what kind of insulin regimes are there, because the challenge comes the moment you tell patient, I will like to give 2 injections, I will like to give 3 or 4 injections. Patient accept the once a day basal insulin. So you need to understand the need of multiple injection insulin therapy, and that is the reason the once a week insulin which is coming will be very well accepted, because once a week patient don't mind having a prick. So you need to be very careful about multiple daily injection regime if the patient requires that. Advantage of multiple daily regime is it mimics the physiological response and allows flexibility of the meals. Disadvantage is that more insulin injections are required, but that's a different issue. Then we need to be very careful about that where do you inject insulin. This is also very important and very important. You should also know when you treat the patient with insulin, what are the values in ICU setups and what are the values in non-ICU setup. This is another challenge. In all ICU setups, the average sugar should be between 140 to 180, which is very important. This is one of the very important slides. When we talk about insulin therapy, you need to change the sites and give at all the different sites that the injection where the patient is taken on first week of July, the first week of July or first week of any month, like you need to be very careful that over the period of 3-4 months, August, September, October, patient won't develop the lipodystrophy. So if you look at this, normally this is the way insulin injection is given. So another challenge when you start the insulin therapy is to educate patient about insulin therapy. Some people are scared of taking insulin on abdomen. Then you can say the insulin can be given on thighs or arms. But the absorption of insulin from abdomen is maximum 94 to 96%. Thighs are 94 to 93%, and arms are 92 to 93%. The lift the skin, and it has to be given in fat, not the intramuscular. I again repeat, sir, the another challenge in making the patient aware about insulin therapy is give patient opportunity to try in front of you, give within the fat. Intramuscular should be avoided, and we'll ensure that there is no lipodystrophy over the period of time. So this is the way you need to educate the patient. This is a very important slide, sir. You should know about it, that needle should be oblique needle, go into the fat only, not into the muscle, to have perfect glycemic control. Now, it is very important that always look at the insulin for parties or unusual color. If it looks that different, like always suppose you have an insulin pen or insulin bottle, if the cover has same but the insulin color has changed, crystals have been visible, probably don't use. So any profile of the insulin if changed, keeping in fridge or outside, if the profile is changed, please don't use it. This also you need to be very careful. When you give oral medications, you have no issues. Just you prescribe once and forget. But with insulin, you have to check the vials. If there's a pre-mixed insulin, sometimes you have to roll between the hand for proper mixing. Otherwise, intermediate and long acting will not be mixed properly. Now, when you start insulin, another challenge is that you need to educate patient attendant about hypoglycemia, especially school-going juveniles. While using insulin vials, match the unit concentration and syringe strength. This is also another challenge. Patient might have 40 IU insulin per ml, and you may get a 80 IU insulin syringe. So that when you take same insulin syringe, then patient will have lesser insulin. You may have patient 80 unit insulin per ml, and patient may have 40 unit IU syringe. So the patient will have concentrated insulin, and the patient may go into hypoglycemia. So it is very important that patient should have the total awareness along with the doctor about the needle, the brand, and the strength of the insulin which is being used. Is a 40 units per ml or 80 units per ml. Patient concerns about insulin are fear of injection. This is the biggest challenge. Perceived significant need of insulin has to be there. Worries that insulin could worsen the diabetes. Please correct. Insulin will always correct the diabetes. And patient have a one question that एक बार insulin लिया तो जीवन भर लगाना पड़ेगा. In many of the patients, if the good glycemic control achieved, we are able to reduce the doses or stop insulin. But once a patient requires insulin, patient become insulin opinion. Try to educate him that the moment sense of well-being come, you will feel very happy that it was the right decision to take insulin. So worries that insulin could worsen diabetes, please clarify this. Concerned about hypoglycemia, you have to be very gentle in building up the doses to prevent the hypoglycemia, and complexity of regime should be avoided. Ideally is basal bolus, but if patient resistant, give premix. If patient resistant, if you may give at least basal insulin, so one part of the diabetes you correct very nicely. So barriers to insulin therapy are very common. Worsening of insulin resistance, it may require high doses, more cardiovascular risk, but reduction in plasma glucose improves cardio. Weight gain is another challenge with insulin. Hypoglycemia is another challenge with insulin, and we need to overcome these. Psychological resistance to insulin could be there in the patient level. Like, for example, we had a medical student. In spite of having learned all about insulin, he was in a great denial mode. They tried procasting the insulin therapy. They give difficulty with in taking the insulin, the fear of losing or alienating doctor or healthcare, fear of professional anger, insulin uses is time consuming. So there are many people who will find some or other reason, some or other bahana to avoid the insulin, but we need to be very patient to deal with it. And we have the difficulty with uh, confrontation, with disagreement, fear of losing or aligning patient, and fear of hypoglycemic event, which is very important. Address the patient concern, promise the patient support and closer follow-up when you put on insulin. And another very important challenge, that right selection of insulin is very important. Whether we have to give basal insulin, NPH, glargine, datimir, cost of insulin into consideration, duration is considered, bolus regime, human or analogs. As I said, analogs are more physiological because they mimic the first and second phase of insulin therapy. And then premix, we have human insulin 30/70, premix analogs 25/75. So another challenge in treating the patient insulin to have the right selection of the insulin so that we treat them very adequately and scientifically. These are the various durations of the insulin therapy. You should have on tips that how basal insulin is having long flat curve, how short acting insulin effect weans within 3 to 4 hours, so you need to be careful. So type 1 diabetes should be on basal bolus insulin regime to control glucose while minimizing hypoglycemia. The challenge is to minimize the hypoglycemia. However, over the time, most type 2 diabetic patient will also need basal and mealtime insulin to control hyperglycemia, which is very well important. And as I already talked about, the practical strategy in type 2 diabetic patient is continue the oral agents and add a long acting insulin in the dose of 5 to 10 units, which may gradually build up to 10 to 15 units over 4 to 6 weeks, and hence we can have perfect glycemic control, which is very important. Meal bolus insulin has to be there, and we need to adjust the doses of carbohydrate intake as well as the meal type insulin. Higher the carbohydrate, higher will be required of meal type insulin. Then we are trying to duplicate how the pancreas works in releasing insulin for someone who doesn't have diabetes. So role of insulin is to mimic the pancreas. And once the body doesn't know it is insulin coming from outside India, inside, and has a good quality of total pancreatic supplementation done by insulin so that the patient is a good thing. The carry home message is that early initiation of insulin in type 1 to prevent glucotoxicity. But here the challenge is convincing the patient and deciding the type of insulin therapy, as basal bolus is best, but his lifestyle and diet is important. Second, moment there are signs of secondary failure, basal or the combination therapy. So another challenge with you is that to pick up when the patient has developed secondary failure, to pick up the insulin deficiency state, to pick up that in spite of 3 drugs the patient is losing weight, you need to introduce the basal insulin. Third challenge is micro and macrovascular complications are detected in type 2 diabetes. The moment they are detected, initiate insulin. So you need to convince the patient that you have already affected kidney and eyes, better insulin need to be introduced. Last important challenge is that the patient might have acute MI, stroke, or CLD with nephropathy on oral drugs. As in all the rural areas, they never think of insulin. They come to you with all these complications. Convince the patient that insulin is the need of hour to prevent these complications, which is very important. So for all the physicians, I have an advice: don't wait forever. Patients need insulin therapy, and learn to convince him, learn to overcome the barrier states, and you can start insulin therapy right in time before complications develop. Don't be afraid of hypoglycemia, but be aware of it. This is another challenge, so be aware of it and educate the patient. Consider combination therapy wherever is required, and don't under insulinize. Under insulinization is another challenge in our country. The patient requires zero point 0.5 to zero point 0.6 unit of insulin per kilogram. Patient many times requires much higher dose of basal bolus insulin, and he continues 8 to 10 units every day. So one of the very important challenge in good insulin therapy is, please do not under insulinize patient. Hence, I would like to summarize my talk. Identify candidates for insulin therapy. Very high HB1AC is very important. Patient not at goal, the maximally tolerated combination therapy. Patient is not at goal in spite of best of drugs. Select the appropriate insulin replacement, basal or the bolus. Initiate basal insulin with 10 to 12 units per day at bedtime. Adjust the insulin doses on day-to-day basis on advice of patients, and expected therapy outcomes are maximum best with the insulin, which is very important. So I conclude that all type 1 diabetic patients require insulin. All type 2 diabetic patients who have the insulinopenic stage, call it secondary failure after 2 to 3 drugs, not able to control the blood sugar, diagnosed by constant losing weight and rising sugar, insulin need to be introduced. The resistance to insulin therapy has to be very politely, very effectively made to understand to the patient. We have to be very careful about hypoglycemia, not only patient but us. We need to educate every patient whom we give insulin that look, if there are symptoms of hypoglycemia, घबराहट होना, पसीना होना, बेचैनी होना, uneasy feeling होना, low feeling होना, please do eat sugar. If the sugar becomes 200 to 500, is no risk to life, but it becomes 40 to 50, it is a risk to brain and the heart. So educate patient about managing hypoglycemia, educate patient about small frequent meal, educate patient about restriction of the carbohydrate time, educate patient about the insulin regimes will be selected whichever suits him. So sometime we need to modify the insulin resistance as per the patient's requirement or as per the patient whims and fancies, so that at least we are successful in initiating the insulin. Thank you very much.
Thank you, sir. Thank you so much for an insightful talk. Now, with your permission, shall we take the questions?
Yes, most welcome.
Right, sir. Sir, the first question is based on your clinical experience, what are the most common barriers to initiating insulin therapy, and how can physicians address these challenges?
The biggest barrier is lack of understanding of physicians that this is the time to start insulin in type 2 diabetic. Obviously, in a type 1, there is no shortcut. We have to start insulin to pick up the time when insulin should be introduced, make the patient aware that these are the strength of insulin, educate him that the newer insulins are not causing enough hypoglycemia, and make a tailor-made regime for the patient. If the patient is educated and compliant, give basal bolus, that is short acting before each meals, and bolus at the bedtime, basal at the bedtime. If the patient is resistant of not taking insulin 4 times, give twice a day. If the patient doesn't want to take twice a day, give only basal insulin. And then a first injection can be given by a physician himself in his clinic, or may help the patient to take the insulin by his own hand in presence of insulin, just by taking a sample 2 units, so that they realize that it doesn't hurt. It is a needle phobia which is much more. And I reassure you, in most of the patient, this needle phobia goes off if you make the patient to take one sample injection or just make a prick in front of you, and they most of the time say, "Sir, kuch feel hi nahi hua." That is the way insulin is accepted better. Second is, you have to tailor make the type of insulin requirement as per his need. Thirdly, the very common question every patient asks कि साहब एक बार इंसुलिन शुरू किया तो जीवन भर इंसुलिन लेना पड़ेगा. तो explain to him that if your sugar is wonderfully controlled, you could give another trial of the newer anti-diabetic drug which doesn't require beta cell presence, like SGL2 inhibitor or DPP4 inhibitors or glucosidase inhibitor. So try to convince. And thirdly, teach yourself the technique of insulin giving. Most of the patients are not aware of taking. They just put insulin one at one place and they tell lipodystrophy. So educate the patient of site of the insulin therapy. There are no pains when you give insulin therapy. The sense of well-being which they are going to perceive. And sometime you need to be so firm that because of my request, you take insulin for 2 weeks. If you don't like, I'll stop it. But the sense of well-being is so strong with the insulin therapy that most of the patient continue.
Right, sir. Thank you so much for sharing this. Moving on to the next question. So, could you elaborate on the role of adjunct therapies alongside insulin in managing patients with severe insulin resistance, particularly in obesity-related diabetes?
Yes. Look here, whenever diabetes type 2 is diagnosed, the first disturbance is the insulin resistance, not insulin deficiency. All those people who have high BMI or overweight or obese, they have insulin resistance is an important component. So unless you address to insulin resistance, by addressing insulin deficiency with insulin will not get you the proper results. So try to reduce the weight of the patient, try to bring about the BMI of the patient to optimal, that is up to 23, and try to restrict the carbohydrate content in the diet, so that, and there are drugs effective for insulin resistance, and there's a metformin which is an age old drug which most of my patients are on metformin. The other drugs which also help in reducing the insulin resistance are the other anti-diabetic drug like DPP4 inhibitors or GLP-1 agonists and pioglitazone, thiazolidinedons. These are all the drugs which help you to reduce insulin resistance. But more important is calorie restriction, carbohydrate, the balanced carbohydrate diet, and the weight restriction and effective physiotherapy of 30 to 40 minutes of at least brisk walking or treadmill every day. So, exercise, diet, and the drugs combination will bring down the insulin resistance, which is an integral part of all type 2 diabetic patient. Yeah.
Right, sir. Thank you so much for explaining it so well. So, taking one last question for today. The last question is, sir, what emerging therapies or technologies in insulin administration do you believe will have the most significant impact on patient outcome in the coming years?
Yes, the one of the revolutionary thing in insulin therapy is the devices. Look, the acceptance of pen is so phenomenal, so convenient. It doesn't affect the professional work, it doesn't affect the travel, it doesn't affect the social function. Patient puts the pen and just takes a prick. So devices have revolutionized the acceptance of the insulin therapy. They are doing wonderful. The newer devices or insulin pens are really helping in all type 1 patients as well as very high insulin requiring type 2 patients where we can use it. So all these devices now the inhaler insulin is coming, which is under experimental stage with a device to give a puff and the insulin level goes into your nose and it is very effective. So devices have revolutionized the acceptance of the insulin therapy.
Right, sir. Thank you so much for answering all these queries and clearing the doubts of audiences. So, with this, we would like to conclude the session for today. But, sir, before that, I would like to thank you for putting your effort. Thank you so much, sir, putting your effort and your
Thank you.
invaluable time for this presentation and then answering all the
Thank you.
queries.
Thank
Thank
you.
you. Thank you so much, sir. Have a good day ahead. Thanks to all the
Thank you,
audiences for
ma'am. Thank
joining
you.
in. And yes, sir. Thank you. Thank you all.
Thank you, ma'am. Thank you.